This meeting is now being recorded.
Yeah, we got.
Hello?
Hi.
Hi, this is Tracy with the Northwest Colorado VNA.
Oh, hi. Hi, great.
Aware that myself and Angela, the new RN case manager, are here.
Great. So we've got a full house here. Thank you. So for my team, I have the notes on both sides of the table in case you need that. So this is a post-award meeting. It's required by the state for all contracts. So what we're going to do is talk over some of the things you've already seen that are in our toolkit, some of the things that are in your contracts, and really just go over the requirements of the program and ways that we can help you with technical assistance throughout this program. So the statements on this slide are really from the statement of work, which I recommend that you take a look at. Please familiarize yourself with the statement of work and the toolkit and your entire contract, what is the content of that contract in any of the documents that I talk about today, because you are required to comply with the requirements of these documents. You may not change eligibility of eligibility requirements of the program without our approval, and we need you to report any changes to your staff working on this project or on this grant within 15 days of the change. This contract has officially begun and goes through August 31st, 2017. So it matches the service delivery clinical services contract. And I'm going to let Kristen say hello.
Hi, my name is Kristen Laura. I'll be helping with the ECAST parts and reimbursement parts today. I'm in our health informatics group and resident data guru. You all probably know and already love.
They probably. We've got some new people who don't know you
yet.
Yet.
I've been with the program for 5 or 6 years, and I used to be the WWC data manager and for the colorectal program, and I oversee ECAST, all things ECAST.
So she's the one who has really updated ECAST for this program for us, and that's why she's training. Okay, thanks. Back to the slide. So the period for your actual care coordination delivery is February 1st through June 29th, and every year. So every fiscal year ends on June 29th, and will begin, the new fiscal year begins on June 30th of that year. So this whole contract goes to 2017. It's just like your other WWC contract.
Clinical services.
Clinical services contract.
The people next door to us are very jolly and laughing.
So we hope that we're, so we can, hopefully our noise will dominate what you're hearing. We don't know. So the Women's Wellness Connection Care Coordination Grant Program is a separate contract from your clinical services, service delivery contract. What we're talking about today really only applies, what we're going to talk about are differences between the two contracts. So what you will need to do is, in general, follow the program guidelines for WWC, but also specifically the program requirements for this particular grant. So we have a toolkit, and with all our program requirements, but we have specifically a section for the toolkit for this program. So the purpose of this grant program is to provide those breast and cervical cancer screening, that care coordination services to women who have or are eligible for health insurance and who meet the age, income, legal presence criteria. And our overarching goal is to increase the number of women screened for breast and cervical cancer in the state of Colorado. You can say something, yeah.
I was just, you'll hear us, we're trying, now that we have kind of multiple projects and programs going on, to be a little bit clearer about what care coordination, what might be outreach with some other there's another group of contractors, and so we're trying to clarify that WWC is more than just what we all just thought of as the clinical services. So we're trying to kind of interlude clinical services when we mean paying for actual clinical services, but it's pretty new to us, so we forget, and we sound funny saying it, but you all are the first we're trying that out on to differentiate the two between clinical services and care coordination.
Correct. So you guys, I don't want to call you guinea pigs, but we are kind of testing the waters to see how things feel with you guys and trying our own phrases with you. So the beneficiaries, this is straight from our contractor, are for this program women in Colorado who are actually insured or eligible to be insured, and women who meet the age, income, and lawful presence requirements. I left this slide very much like the clinical services presentation, because really we are looking for these same target populations when possible and survey them. So we've got a little history. We didn't just create an RFA last October and without some other things going on. So last fiscal year, 2 agencies volunteered to be part of what we call the Care Coordination Pilot Project. And they did the same work that you're doing for this grant. And we learned a lot from these 2 very different agencies, Boulder Valley and Peak Vista, about how they implemented the program, what it took, the work that they actually had to do, their interactions with clients, and those kinds of things. So we learned, got some great feedback from them on how to improve the program. Some of their suggestions we were able to include in this new grant, and other things we just couldn't implement because of contract issues or just practicality of ECAS and things like that. What we heard from these 2 agencies, we asked what are the 2 best things about this project, and they said that financial compensation for case management is beneficial to the organization, and the data for care coordination was integrated seamlessly with the WWC program, and it made data entry simple. So that's good to know for you guys all to hear. And helping ladies navigate through the system for annual exams who would not have known which steps to take. And also informing them as to what their Medicaid was covering. So, a lot of these women are brand new to insurance and Medicaid. So having that opportunity to assist them. Emily.
All right. So this is sort of what I was talking about. This is a little graphic I just created, and we're still kind of refining, but just wanted to give you this to see where care coordination fits into the overall WWC, kind of as I was explaining earlier, that WWC now is more than clinical services. So you see, this really shows our broadening focus, like the size of the circles don't really matter, and it's really based on the socio-ecological model, if you're familiar with that. So if you can see that little purple circle in the middle, clinical services, it used to be where we did almost all of our work. And now with the implementation of ACA, we're broadening that to do more with care coordination, which is what we're talking about today, clinic quality improvement, and then awareness and promotion of breast and cervical cancer screening. So there's a lot to all these different circles, but I just kind of wanted to show how that, that care coordination is really encompassing the clinical services, but it's that broader picture. And obviously, we've always done the care coordination for the women. You all have always done it for women who we also paid for clinical services for, but now this is broadening it to providing that care coordination for a group that we didn't previously serve. Well, really, they might be the same people, but eligibility has changed as far as insurance. So I just want to show you that. I am hopeful it helps kind of visualize what we're doing, what WWC is doing. I've used it to explain to a couple people. If you have feedback on it, feel free to email me. That's where care coordination fits in. So we're really excited about this broadening focus in this new route. So thanks for being part of it with us.
Yeah, absolutely. So you probably heard your agency name and other agencies listed when I did the roll call, but we've got 14 agencies who are doing this work, all service delivery clinical services agencies. So you've all already had a WWC contract with us, and so we're thinking, we're hoping that the addition of this grant, it will be fairly seamless. We hope that there will be an easy transition to add in this population. We are also adding or going to do another RFA soon to
once we write it,
have time to breathe. Once we get you guys started, we're going to try and add more agencies. So our hope is really that almost all of the traditional WWC service delivery agencies will also be working on this care coordination grant program. Thank you and congratulations for starting a new endeavor. Okay, so we're going to kind of go through this very much like the toolkit. A couple of you were on the orientation this morning, so it's very similar. So agencies must determine if clients are eligible for WWC service delivery or the care coordination program. So you will have a woman come in who is at or below 250% of the poverty level. She will be lawfully present. She will be between the ages of 40 and 64. And then the kicker, your decision maker for which program she belongs to is her insurance status. So if she is insured or eligible for insurance and you help her get enrolled, she's part of the care coordination grant program, and that's where you enroll her. If she's uninsured or underinsured, she's part of service delivery clinical services. So I think one of the important pieces, there are two important pieces here. Eligible for insurance. If she is eligible, please refer her or help her get that insurance, and then she has that benefit. And then she's also part of the grant, the care coordination grant program. Enrollment is very similar. Probably the main difference is that, two differences. We've got a form for you, a consent form that's combined WWC and care coordination grant program. So, and clinical services. I was calling it the wrong thing. Sorry, I can't help myself. So we've got a combined form, and we sent that out to you last week or the week before. Last week, and so you don't need to have two different forms at your agency for this population for enrolling. So you don't have to say, oh, which program is she in, and then get out a different form. Hopefully this combined form will be helpful, and They will be posted on our website, so, but we will be sending you copies as for this time. Yeah.
I just wanted to add that we had sent that out last week, and we have already had a revision to the consent. One of our agencies requested that it be put in grayscale because they were not able, their agency wouldn't allow them to print in color, so we had a blue box and a green box. And we have updated that, so they're both gray boxes, and instead of blue and green, we added left and right as boxes. So those will be released in the coming days.
Great.
But the one you have is fine.
But the one you have is fine, and we can send you the other one. So just like care or service delivery, enrollment and participation is voluntary. Clients enroll by completing the required forms for care coordination grant. That's the consent form and the lawful present affidavit. We are not requiring you use the client profile tool, but you're going to be entering clients into ECAS and using the very same data you use for WWC. So, you know, obviously it's your choice. For data entry ease, if you're using that form for WWC, continue to use it for this program.
Hi, Chris.
Yes.
It's Rocio.
Hi, Rocio.
Are they going to be in Spanish also, or is it the same forms?
Yeah, we've got one in Spanish already, and Vietnamese.
The consent.
The consent.
And then all the other forms are the same as WWC clinical services, so they're already in Spanish or Vietnamese.
Yeah, so the client profile tool is already in Spanish and Vietnamese, and we have templates for the lawful presence in Spanish and Vietnamese as well. And FYI, we're looking at getting these translated into other languages. Just don't have to switch ones yet.
Feel free to email us if there's a particular language that would be especially helpful for either clinical services or service delivery. I'm guessing we covered it with like 10 additional languages that we're considering, but we'd love feedback on that.
Yeah, exactly. I think something we probably mentioned later, but I want to tell you, I want to bring it up now also is a client cannot be dual enrolled. She needs to be WWC or care coordination. So she needs to be service delivery or care coordination. So keep that in mind as you're enrolling and considering your processes and your procedures.
Chris, can they go back and forth between care coordination and and clinical services?
So can they change their mind partway through? Can they have a different status?
Can they have a different status? So they did not have insurance. They qualified for WWC.
Then they got it?
And then they did get insurance and no longer qualify for WWC.
Oh, yeah, then
go
they
back
can.
and forth.
Yeah, okay. This is Kristen. So you need to, in the end of the day, choose either WWC or service delivery or care coordination. But if you start a woman, for example, in service delivery, and you start her Medicaid paperwork, let's say, at the same time, but you give her some of her service delivery services, like her PAP test or HPV test, she doesn't have insurance yet, so you are going to charge them to WWC, you're thinking, and then it comes back and she, qualifies for Medicaid. At that point, you have to make a decision about whether or not, one, did Medicaid back enroll her? So did her Medicaid, was it effective the day that her paperwork started, so maybe that PAP and HPV can be covered by Medicaid? If that's true, then you could switch her over and indicate in ECAS that she has Medicaid and list Medicaid as the funding source of all the procedures. ECAS would know to automatically change her from one funding source to the other, so you can switch back and forth. You could also make the decision to say, okay, well, I'm not going to ask for her under care coordination. Instead, I'm going to list WWC for the initial procedures, Medicaid for the later ones, but I'm going to ask for the C3 for that PAP and HPV, for example. And ECAS won't balk at that either. It'll just leave her in WWC, and it'll know that the care coordination that got her through her COLPO ended up not being paid for through our program. We only paid up through that C3. So you got to choose one or the other in the end of the day, but if you change your mind, that's okay.
Okay, good. Thanks.
And we can show that in a little bit. We'll get into the ECAPS and I can show you how that works.
Okay, wait. Whoops. Okay. Care coordination. Angie, were you going to?
Sure. So I'm going to talk about patient navigation as part of the care coordination grant program. The contractor shall provide a clinical assessment of the need for breast and or cervical cancer screening for each woman based on nationally recognized screening guidelines. Agencies must not subcontract for patient navigation or case management services. Activities currently done by subcontractors, such as reminder calls, or follow-up calls, or notification of results are acceptable. For the program, clients in need of screening, patient navigation services must be provided to assist them through completion of the screening procedures, which includes the mammogram and or the PAP and HPV test. This is to enable the client to move through a complex health insurance and health care system. Patient navigation services are reimbursed at the B7 and C7 levels, so we have yet again additional levels to our BPS.
I know you're excited.
Chart. I love it. Love it. The agency must provide the following as part of navigation. You must assess and resolve and potentially remove the barriers to completed screenings. This could be transportation, language barrier, and health literacy. And you must collect and enter data into ECAS for all screening procedures provided through the program, including funding sources. And remember, the funding source will not be WWC in this case. For the case management portion of the grant program, case management is required for all abnormal screenings. The client must be notified of the initial abnormal result within 2 weeks of the date the procedure was performed. You must arrange the diagnostic appointments for the client. In most cases, this is preferred. And then we are going to follow the same loss to follow-up refused service policy as WWC, and that policy you guys are, I think, mostly aware of and implement already. The policy can be found in the toolkit if you need a refresher. For case management, you also need to complete data entry for all the procedures, the diagnostic procedures provided, including the funding source, and again, this will be a funding source other than WWC. Case management services are reimbursed at the B8 and C8 levels.
Are there any questions about patient navigation and case management?
Star 6 to unmute.
Yeah, star 6 if you're muted yourself.
I have a question.
Yes, go ahead.
You know, are we supposed to know what Medicaid covers and what it doesn't cover? I'm not sure of all that. Does it vary per patient, or?
I would think someone at your agency knows that. Who is this? Which agency?
This is Dee Patterson from Penrose.
We can tell, I mean, we have contacts at Medicaid. That's a good question. We have contacts at Medicaid, too, that usually respond if we say, hey, does Medicaid cover this or that? You know what we have, actually? Don't we have that women's health services thing from Medicaid? We can send that out. That I think it specifies what, doesn't it, Angie? Specify what's covered?
I'd have to look at it again, but...
Well, yeah, we'll see what resources we can find for you.
Okay.
I would wonder, as Chris said, maybe your billing staff or who maybe does your Medicaid billing might have a sense of what is denied and what is not. And then you can always probably contact Angie Angie's most in contact with Medicaid. If you're like, here's a weird thing, is this covered by Medicaid?
All right. I
just
know if it was sometimes different with each patient. You know, will they cover a screening, but they won't cover a diagnostic, or I wasn't sure about that.
Yeah.
Does that vary at all? Do you know?
I didn't think so, but I don't know.
I don't think it varies, but let me find that document, and I can either send you the document or the link, and then I'll also follow up with Diane and or Kirsten at the Medicaid office to see if they have additional resources.
Okay, great. Thank you.
But that will be true if they are on private insurance. I mean, that does differ probably by person and plan.
Yes.
And we're probably not going to be helpful in determining that for you. So for that, your resource really would be probably your billing type of
the health benefits advisor. Normally that's what we would go through. So I was just curious about the Medicaid, if there was anything that you guys might have on that. So I can go with that as well.
As far as I know, it's pretty standard, but I just wonder if they don't have things like, if they have a history of X, we'll cover that, or if they've previously had Y, then we'll cover. I don't know about that.
I would also say for private insurance, if you do encounter insurance plans that are not covering screenings in particular, it would be very helpful to know that you're encountering that and with whom you're encountering it, because those should, by law, be covered, but there are some insurance plans that try to get around that. So that's very helpful information for us, because we can share that information internally and get the right person to speak up or speak out about the insurance plan not following the law about providing preventive services free of charge. So let us know if that happens.
Okay, thanks.
Good question. Any other questions? Feel free to jump in anytime, everyone. Okay, clinical services, Angela.
So I'll talk about clinical services, and this is pretty simple.
Yeah.
Clinical services are not reimbursable through this program. So agencies are required to comply with the guidelines stated in the clinical services section of their toolkit. But, as I just said, breast and cervical cancer clinical services are not reimbursable. All references to the clinical services section to reimbursement of clinical procedures are not applicable in the CCGP program. Agencies must be contracted as a Medicaid provider and or successfully bill private insurance for these services. Did you want to say something, Chris?
No. I have a question.
Yes.
This is Oshana at PVISTA. So even though the clinical services aren't being reimbursed, we still should be data entering those, right?
Correct.
All right. Thank you.
Because that is how you're getting reimbursed.
Correct, yeah.
So what this also means is that pre-approval for certain procedures, is needed when you're in direct services, but as a CCGP client, pre-approval is not required. So this is for like those MRIs or any of the second biopsies.
If their insurance will cover it.
Yeah, their insurance should be reimbursing for that. A mammogram is required for CCGP breast screening reimbursement at the B7 level. Any questions on that?
I have a question. This is Jessica from Denver Health. Say we do see a woman who has private insurance and it does cover her screening. She meets all the eligibility requirements, but with her private insurance doesn't cover diagnostics. Would that be a switch back to WWC?
She would be WWC. Well, that's, again, where you make that choice.
Yeah, you get to choose. Ultimately, you have to choose one contract or the other, essentially, that you want to be paid out for by client. You can't be paid out of both contracts for one client, so your direct care service delivery piece or your care coordination piece. So whichever feels like the right fit for your organization, if it is entering her as a diagnostic referral into the WWC program, for payment of those diagnostic services, or getting the navigation and case management funds from your care coordination contract. That choice is up to you, and really the way that you identify that distinction in ECAST is both through who is funding the procedures and then what insurance status you list for her. So, so if you wanted to put private insurance but high deductible, that would indicate that she was on the direct care service line, for example. Does that help?
Yeah. So
Did I answer your question? Yeah.
Yeah. So it's either one or the other. Can't go between the two.
Yeah. And in that case, I mean, just for me, you have to decide on your own agency, but you're going to you would be out a lot more money on the diagnostic than you would on the care coordinator. So it probably makes sense to then switch them to
WWC.
Yeah, because that covers the case management of the diagnostic.
All your active patient navigation.
Yeah.
Okay. All right. Thank you.
Thank you.
So I just want to reiterate that a mammogram is required for reimbursement at the B7 level, and cervical health history and education are required for reimbursement at the C7 level. And then the tobacco use assessment policy is the same requirements as our direct services or clinical services. This slide just talks briefly about the treatment referral services. CCGP clients cannot be enrolled in BCCP Medicaid because they have insurance, so they're ineligible for BCCP Medicaid. The agency must coordinate treatment services for these clients, and the agency must establish relationships and or subcontract for referral services for the treatment. And you'll want to be sure to establish these relationships and subcontracts prior to offering any CCGP services to clients so that you know that you have a place to send them.
Thank you. So agencies are required to comply with the guidelines of the quality assurance and improvement section of the toolkit, with a few exceptions. So the CDC does not require specific clinical measures for this program. However, we did receive funding for the Care Coordination Grant Program by indicating that these indicators would be gathered and reported in aggregate to the CDC. So we don't do this data will not be included with our data submission to the CDC that happens twice a year, but we will report twice a year also at different times on the data collected for this program. So we will review and report performance to the agency, to you. Again, the same times as with clinical services, 3 times a year, March, November, and August. We will not report to you this March. I don't think we will have anything to report. But again, we're going to be looking at the same clinical indicators for completeness of care and timeliness of care for these clients for breast and cervical abnormal cases. And we also will be looking at a couple of indicators that one of them will be look very familiar to you from service. See, like I said, we're going to be stumbling over this. Over clinical, I need it in front of me constantly. Can someone write it on the board? Thank you. We're going to have a data entry timeliness indicator, just exactly the same. We want to see 90% of services entered into ECAST within 30 days. And we're also going to look at, thank you, we're also going to look at a new indicator that 35% of the clients in this program who are 50 and older are also receiving clinical or cervical services. So, cervical services and breast services. Okay. Everybody said that. So again, we are probably going to develop some kind of progress report to report back to you on these indicators. Because this is a state contract, we will be doing this 3 times a year, and we will be providing you also with the contract monitoring, the CMS ratings. And in these 5 categories, your agency will receive either a standard or below standard in each category for each performance period, and then an overall rating at the end of the contract. So that will be in 2017. So you'll receive a separate CMS email for this contract and for your clinical services contract.
Data entry and documentation. Okay, so as was asked earlier, all clinical services must be submitted into ECAST. This includes all the procedures that we're not paying for through the service delivery grants.
You want to see that?
Yes.
Okay, thanks.
As well as the care coordination that you're providing. There isn't any additional data entry beyond the routine data entry for ECAST that is required. So you have to enter the initial procedures that are performed, follow-up recommendation, and a referral recommendation into ECAST. As Chris mentioned earlier, the data for these particular clients is not submitted on a client-by-client, record-by-record level to the CDC, but we're still required to adhere to those same clinical benchmarks, and we are required to report the total number of clients served in aggregate to the CDC. And they do count as part of our direct care services that we provide or are funded through the CDC. Authority to collect the data comes from state law, and let me make sure that is, if you were interested in that, it is referenced in the toolkit, as is all of this good data entry stuff. Okay. So the agency must complete data entry on all of the following topics. Again, remember, this is just like regular ECAST data entry. It's really no different other than that you're listing a different funding source and or a different insurance source. So you have to enter all that demographic information. It's done on the client profile tool. The profile tool is not a required forwarding one.
Correct.
So however you want to get that information, so long as it's available to enter it in the ECAST. Breast health history, health education, and a mammogram with funding source. I
don't know why I didn't include cervical. Yeah, no, that should have been there. And cervical.
So, all that health history information, all the clinical services, and their funding sources, and that follow-up recommendation. Really, truly nothing different than regular WWC data entry.
Correct.
This is all WWC data entry.
That's what we're trying to say.
Yes. Diagnostic procedures, funding source for each of those procedures, and final diagnosis information. So all same as usual. I can tell you that not in this pilot project, but one of the demonstration projects we had for care coordination years ago, it was sometimes a little difficult to get diagnostic information. So I'll just kind of warn you about that. Just because we weren't paying for it, it was a little bit less of a carrot from subcontractors. So we do still really need that information in ECAST. ultimately what the way the CDC has decided to kind of view care coordination is that ultimately the outcome measures for care coordination are the clinical outcomes. So if you're providing strong care coordination, it'll show in your follow-up rate. It'll show in how many women got a mammogram. It'll show in how many women got a Pap test. So that's the reason why we require collection of all the clinical services, even though what you're providing is care coordination.
Right.
Okay, perfect.
Are you guys seeing the public chat questions on the side of the screen?
We are not. Please ask us our questions. I can do this actually because I have to get into email.
Or ask us your questions.
We're seeing no, oh, whoa.
Whoa, a lot. Okay. Switch. Okay, so she asked about switching.
Go up.
Oh, aren't we at the top? Okay, we're not.
Okay, yes. So Ashley Shirley's question.
Thanks, Dana, for sending the link.
That's actually just the webinar link. I actually was looking for the link to print out the slides to make notes.
Oh.
You don't have that.
You don't have that. I know.
We'll send them.
We'll send them later.
We'll send them or post them after, don't worry.
Okay.
We just finished them 5 minutes before.
Yeah, sorry. How did you determine the percentage on 35%? That's a good question. I think it was pretty much that was just a guess about how many women that would be, and I think so even though this isn't the pilot project, we're still learning about what is possible or what is reasonable. So
on really all of these.
On really all of them. So even though we're using the same measures for completeness and timeliness, we're going to be learning about what is the reality for these things. So, keep that in mind, and that this is really still a learning portion of this work.
And I believe it was based on Connect to Care.
What is this measure exactly?
35% of women 15 older have received both services.
35% of the women receiving cervical
also receive a mammogram. I don't know what we exactly used to determine the 35%. What I can tell you from the pilot project is that both agencies came in around 60%, so we felt like the 35% from those two sites felt really very comfortable. But as we kind of move forward, we can continue to gauge and assess that. Does that help, Pat? You may be muted.
Yes, that helps. I thought you had a formula that would make sense.
No sensible formula here.
Yeah, and we may look
create one with this.
We may look very different than the sites you tested at. So
yeah,
I'm concerned if I could justify why we had to do that, and people would raise questions. So I'll just say we're learning.
Yeah, this is even though we piloted it, we're still going to learn, and we know we're in that learning phase, and we know you all are too. Part of the thinking behind it was just to ensure that we're screening people for both breast and cervical cancer if we can, and not just somehow ignoring one body part because it was easier or something, so just trying to make sure that
I understand. There are agencies that tend to do almost all cervical, so that's, I understand. Yeah, thanks. Okay.
Did we answer the other question?
No.
Oh, we didn't?
Would she have to re-sign the consent? No, because she signed the consent for both.
Combined consent. Well, she's saying, I'm signing for this, but I don't think, what do you say?
I think they probably would, because on the current consent, we're asking them to choose one of the boxes. Either coordination or clinical services.
So in reality, we should, this is Pat Uris jumping in. That was my question. It would just make sense to have them sign both of them, because we do it through our enrollment office, and then and both programs are explained to them, and then they...
As long as both programs are explained to them
And they
understand which one
Right.
on that day that they qualify for or are being enrolled in, I don't think there's a problem with signing
For both.
Yeah, because otherwise, to go back and find them and switch every time, we'll never go
Yeah.
back. Yeah.
You're right. No, that's a great question.
Oops. I don't know why we're ringing. Let's try. I'm just trying to find here. Where? Go up. Yes.
Okay. Ringing's done.
Fun. We're here.
Hopefully.
So we are going to take a break from the presentation for a brief ECAST interruption. So one thing that I will say, this is Kristen, one thing that I want to say up front is that what I'm going to show you right now is really for someone who already knows how to do ECAST data entry. If you have any users at your site, potential ECAST users for the Care Coordination Grant Program who do not already have ECAST access or are not already familiar with it, they'll need to go through kind of the regular ECAST data entry training videos and get regular ECAST data entry access. And if you're on the call today and you're looking at this, it might feel like we're going really super fast, and it's because we're assuming a high level of knowledge already about the standard data entry. So check back in with me or Nick Rose. He is on paternity leave currently, but will be back next week. So continue to direct your questions to him as you start care coordination, and I'll check in with him as well to make sure that that's going well. But yeah, so we're going to go through specifically the care coordination piece. There aren't videos available for this particular piece quite yet because we were busy getting ECAST ready for it.
We're recording this, so someone else
we're recording this.
Watch it again.
Maybe we'll cut this part out and put it in a video online. So if you're doing regular ECAST data entry, I'm just gonna look up a random client. So usually, let's say that your client is already in the system. So we found this client. We know that this is the client we want to do data entry for. If we go to the profile, as we always should, and just review to make sure all the information looks up to date, we go over here, we scan through, we see normal data ECAST entry. It all looks up to date. I feel very confident about this. She has a previous enrollment. It was fairly recently. It was April 2013. Yes. Oh my gosh, I feel so old. Okay, so it's one ECAST. Hold on, I'll get that. Okay, ECAST. What is it? Oh, that's not all. Can you all? Yep. Oh, you're absolutely right. Thank you. Good job, Emily.
Cindy, you're muted.
Whoa. Why did it do that?
Yeah.
Oh,
Let me go back to ECAST.
I do.
Back to my presentation.
Okay.
Okay.
So, you look up a regular client in ECAST. We see some services from some time ago. We're going to add a new clinical cycle for her. Again, it has to be...
Okay, wait, just a second. I'm muting.
We're muting everybody.
Sorry.
We always keep doing this.
All guests have been muted. You can unmute your line by pressing *6.
Thank you.
Hi, everyone. So press *6 if you need to unmute yourselves, and please feel free to ask questions throughout the ECAST portion.
Don't they have to re-enroll?
Yes, we haven't gotten there yet.
Oh, okay. Oh, I'm sorry.
You don't do ECAST data entry.
I don't get it. Same way.
You can enter enrollment in two different places, from the profile or from the clinical cycle. You guys are more than welcome to do it in either place. I'm showing you the clinical cycle way.
Got it.
But Chris is absolutely right. There are 5 million different ways to do something in ECAST. So, so we're going to select a date that is after the contract start date. ECAST will get upset at you if you enter care coordination client and request money for her, and she was seen before February, so don't do that. Or if you have error messages, check your dates.
ECAS is smart. Yeah. You really don't want ECAS mad at you.
It will find you and hurt you. All right. I'm just going to select somebody I know has an active contract for care coordination. So I clicked add. We just entered the opposite date. Generally the day the client received her breast and cervical health education, probably her pap pelvic and HPV. And here is the place where you can add enrollment. You could also do this very easily from the profile screen, but we do not see our enrollment here yet. We're going to click add a new record. We're going to agree that we have we verified and documented her legal presence. Now you do not see CCGP here. All we see is WWCI. Remember that both your direct care service or service delivery and your care coordination program are both under the Women's Wellness Connection. So that's why we are continuing to select the Women's Wellness Connection as in your program of enrollment. Wow. So that might feel a little weird or different for a while. We're going to select the day she signed her consent form. I'm going to say it was the same day as her office visit in this instance. Here is where really the crux of letting ECAS know if you want service delivery or if you want care coordination occurs. You're going to let us know which of these options best fits this client. So if you're enrolling someone who does have Medicaid, you're going to say, yes, she has Medicaid, and ECAS is going to be fine with that because you have a care coordination contract with us. No, she does not have Medicare. We're going to say her income is $1,000 a month. She lives on her own.
With 14 people.
Lives on her own with 14 cats.
3 of her pets.
Okay, 1 and 2%. It's much better than, I don't know what that was. Screen negative. English. A physician. Okay, these bottom 3 are not required. So again, here, really the most important piece is what type of insurance you indicate. That's the only part that's different than regular ECAS data entry in the sense that you're now going to be purposefully putting people who have Medicaid or who have private insurance in here. Per the example that was brought up by Jessica at Denver Health earlier, if you had a client with a high deductible and you wanted WWC's service delivery side to pay for it, you would select high deductible instead of has private insurance.
Or does not cover
or
screening.
Does not cover screening.
And then you would call us and complain about the insurance that didn't cover her screening.
Yes, please do.
Yeah, let us know.
But yes, so this Medicaid one and private insurance are both things that indicate CCGP, the Care Coordination Grant Project or program, and then does not cover screenings, high deductible, doesn't have insurance. Those are all things that indicate the traditional Women's Wellness Connection service delivery program. So right now we're going to mark that she has Medicaid.
Before you leave the screen, Kristen, this is Angie. With the care coordination, the client profile tool is not required. And what we've heard from people is the most common issue with not using the client profile tool is that the monthly income and number living on income is not captured in registration, either when you're scheduling an appointment or when they're coming in for their initial appointment. So if you choose not to use the client profile tool, just be sure that you're capturing that information somewhere, because you will need to enter it into ECAS. Do you need to enter it for... Wait, do you need to enter it for care coordination?
Yes.
Okay.
You do?
Yes. Okay.
Absolutely.
Yes.
They need to be,
As I said that, I was like, wait a second.
And do let us know if that continues to be a barrier. There are different ways we can collect or document federal poverty level that meet the CDC's needs, so we can, that might be what's popping into your head and you're not sure why.
Yeah.
Because different programs collect this different ways in ECAS. So we can talk about that more if you realize, you know what, we'd be able to do away from the profile tool, but we don't have a good way to collect income and living on income. We have percent of federal poverty level is the only thing that shows up on our system, for example. Just let us know and we can at least start to collect that information and think about what we could do with it.
Thank you, Kristen.
Yes.
Okay, so is there any questions about this entering enrollment? Should be the same as usual, just continuing to enter accurate information. It's just you got a larger or different pool of people you're doing it for. Sound good?
So remember, through this, we still can't see your chats, and if you have any questions, *6.
*6 and, yeah.
Oh, is it in Internet Explorer?
Yeah. Global.
Nope, same one.
It's the same.
Okay. Okay, so I'm going to go ahead and click Save. That disappears, and I'm going to click here. Now I see my second one for 2015. I'm going to mark it that says I want to add something based on this enrollment, and click Create a New Screening. Again, now we're on regular data entry mode. We're just entering the services that have been provided to this client. The only thing that will be different is we might enter a different funding source, whoever paid for her procedures.
Well, we have to, don't we? Or else it'll be all mixed up.
Yes. So
Okay.
if you, but again, regular data entry mode, other than WWC funding source for regular data entry requirements, you know, anything you learned about regular WWC applies here, except that we're entering Medicaid as the funding source. So we're going to indicate that she has had WWC funded breast health education provided. I'm going to point out that you have to have had a mammogram to receive payment through the Care Coordination Project. So, for example, if I write no mammogram done and I only do health education, it won't pay me. Instead, I have to provide a mammogram. So that might be something where you need to feel out or figure out at what point to enter clients in for breast cancer screening services into ECAS, because I know a lot of you guys would enter it after the CBE. And then you're using ECAS to track or make sure that you're remembering to put in the mammograms. So you might need to think through that. I'm not sure if either of the pilot sites has some feedback about how you guys achieved that. *6 to unmute yourselves if you have any ideas. And I'm continuing to do regular data entry, so I'm entering a CBE. This client has Medicaid, so I'm selecting Medicaid here. Entering the result as usual, entering the facility as usual. I know it's a weird, it doesn't say Peak Vista here. This is our training environment, which has a weird subcontractor list.
Nice.
Okay, so I'm just going to show you for kicks. I'm going to click Save so you see what the main screen looks like. So it has a caution flag here. It says two things. So this one's normal to you guys. So pending screening is not complete. This one's unusual. So CCGP, so the Care Coordination Grant Program, breast screenings must have a mammogram.
All right.
Okay, so this could be your reminder to yourself. You can leave them there with a caution flag saying that until you're ready. My only caution to you there is if they don't ever return, we can't reimburse you for it.
Right.
So we're going to go ahead and we're going to add the mammogram. What's that?
Where's your phone?
Sorry.
I thought it was outside. So again, we're going to select Medicaid. We're going to say it was performed yesterday. Fire as 2. Screening. Memorial Hospital, not at the endoscopy center. And then the final step that we have to take is we need to update the follow-up recommendation to indicate that we're all finished with her data entry. So follow routine screening, save. We'll click Save at the bottom. And so now we see a new level here, and number 7.
Nice.
So that is what you'll get when you enter a mammogram into ECAPS under CCGP. Let's go ahead and mess some things up just to show you other things that ECAPS will tell you or warn you about. So if you're, in regular data entry ECAPS mode and you accidentally put this mammogram in but you mark WWC instead, I feel like that was a fairly common, I feel like I almost accidentally did that this morning when I was practicing. ECAPS, if we do WWC, gets upset. And it should say something like CCGP procedure funding source is invalid.
Got it.
Okay. So let's go ahead and let's fix that issue. We'll fix that issue by changing it to Medicaid, and we're all good. So that's probably going to be the most common data entry error that you make, is that you don't want WWC to pay for the procedure. Instead, you want WWC to pay for the care coordination. You want to pay for this through CCGP. Are there any questions about the breast cancer screening? I am going to also enter a cervical cancer screening so you can see that as well.
Star 6 to unmute. So I think just to acknowledge that it is a teeny tiny bit weird, like you kind of want something to enter to say, hey, I navigated this. Hey there.
Done navigated.
Yes. And, ECAS was not built that way, and if we wanted that kind of button, we wouldn't be starting in February. But the idea is, if you think, this is how I think about it, is that in order to get that mammogram, we know that it's sort of happening behind the scenes, that she wouldn't have gotten that mammogram without you navigating it. So I think it is a little bit, maybe it's less weird for you all because it's like us, where that's what we're used to doing for WWC clinical services. But I know the first inclination is like, wait, where do I say? Hey, here's all the things I did for her. So just, we acknowledge that, but we know it's happening because they are moving through the screening process. And then we're paying you for it.
Yep. So let's go ahead and add a cervical cancer screening. I'm going to show you a couple of different things. So again, we'll mark cervical health education. We're going to indicate she hasn't had a hysterectomy. We're going to indicate she's had a PAP test recently, and that she doesn't need one today.
That's more than 5 years.
Not had. She
the
has
alligator
had one
eats the bigger number.
The alligator eats. That hurts my brain. I don't even know how to process that. So, no. So you're going to actually mess me up instead of help me.
You learn it in second grade.
Oh, do you? Okay, so here we've indicated that she had health education and she didn't have a PAP test or an HPV test today. I'm just going to go ahead and click Save to point out that if her services ended here at health education, that is payable at a level 7.
T7. Yay.
So let's go ahead and I'm going to undo that. I'm going to pretend like she had an abnormal just to show you how to get to the higher level, the level 8.
Okay.
So instead we'll say that she did have routine PAP test done, add procedure, and we'll do all 3. I'm going to go kind of quickly here, but again, only thing, I almost went to WWC. The only thing we're doing differently here is we're adding Medicaid. My bad subcontractor list.
Yeah, really.
Okay, so we're here, we see the pelvic exam, we're going to add a PAP test. Again, I tried to do WWC, but no, it's Medicaid. Satisfactory, liquid-based. We're going to put that it was ASCH because I want to show you what an abnormal looks like for the Care Coordination Project program. So now we do see ECAS realizes she's got an abnormal, she needs some follow-up. We're going to go ahead and enter a positive HPV. Again, our HPV is Medicaid funded. So we have our 3 screenings. We see further immediate follow-up required. If I click Save here, you can go back to the main screen just to show you. We will have that caution flag. The caution flag says additional diagnostics are required. So exact same as regular WWC service delivery. We reimburse based on case completion. So this case isn't closed yet. Therefore, it's not saying that it's ready for payment. If you changed this, for example, to loss to follow-up, it would calculate at a level 7 because you didn't achieve any diagnostic procedures being completed. So I changed it to loss to follow-up. Now we are at a level 7. It's a waiting payment. I don't know if you guys realized you could do that or not, but if you've got a green symbol with a number in it and you want to see payment, just click on it and you'll see the billing history here. So this says it's a waiting payment. We're going to click resume, and we're going to say, lo and behold, she came back. We closed that out a little bit too soon. Defaulted to a funny place. Save, so we've reopened the case. We're going to click add diagnostics to add a colposcopy. Again, just like regular data entry, except we're going to select Medicaid as the funding source. Say that happened yesterday. I'm going to make this easy on myself. Actually, I'm not. I'm going to make this hard on myself so that you guys can see what to do when you have a cancer case.
Now, Christine, could you go from Medicaid and change that funding source? Let's say she had Medicaid and now she has private insurance.
If she switched?
It shouldn't matter.
It shouldn't matter.
We can do that, and I'll show you. The only question I almost have for the team and for you guys is, it did get upset at that.
It did.
Let's see why.
She was enrolled as Medicaid, so I think it's looking for it to match. When we signed her up, we said she had Medicaid. So I wonder if it
double checks that.
it's getting mad at you.
Let's
ECAS is getting mad.
You don't want to do that.
I'm jotting that down just to double check. Okay. I'm going to change it to Medicaid for now.
Okay.
But private or fund insurance should be fine. If she switches from Medicaid to private insurance mid-service, both of those still qualify for care coordination. I would think in that instance that you would update her insurance to reflect whatever she had latest. Do you guys agree with that?
Yeah.
The only instance that you wouldn't do that is if you wanted a lady who got on Medicaid midway through her services, but you wanted WWC to service delivery to reimburse for her. You would have to leave that as no insurance so that we know to pay for it. That's the only instance where you don't always update the insurance status to match what she has as of her last service in the screening. So that's a little confusing. That's where you really have that fork in the road and you're deciding, do I want CCGP, do I want care coordination, or do I want service delivery? So here we will add a final diagnosis. I just wanted to show you a more complex one because it will continue to pop up Medicaid eligibility regardless of the fact that Angie mentioned earlier, no clients for care coordination are eligible because they have insurance. So you'll simply always mark not eligible as Medicaid. So I just wanted to point that out, that you will have to fill that out for the handful of clients who end up getting to the point of being diagnosed with the cancer. You'll indicate that they're not eligible for Medicaid, and the reason why is that they have Medicaid or they have private insurance. So we go ahead and quick save here, and hopefully you see level 8 right here. So that is about it. If you, for example, this is maybe not the best example to just end, but if, for example, for whatever reason you wanted to say, no, I don't want Medicaid to pay for this. It turns out she never had Medicaid. This was a data entry error. I don't know.
The portal said she did, but
she really didn't.
Something.
You would just change it to no private insurance or Medicaid. ECAS pretty immediately realized that this was okay because this was okay. It paid for the health education. This is actually really good. It had paid for the health education. It's still totally happy with you marking Medicaid here. So if you want WWC to pay for something, you have to change the CBE to WWC funded, the mammogram to WWC funded. Otherwise, it's going to think all you're asking for from WWC is payment of the health education.
Exactly. Well, and the same thing with the cervical. They had all those other procedures. If you want to get paid for them, got to go back and fix those.
Yep. I don't know why this one has an error, though. I am curious.
We said the Colpo.
It really doesn't like this Colpo.
Huh.
Oh, I know why, because it's upset that it has, you can't have a diagnostic procedure without having a WWC-funded procedure.
True.
So it's confused as to whether or not you want this to be a diagnostic referral. So really the end story here is if you switch insurance to that she doesn't have insurance, you need to go through and review who you need to pay for each individual procedure. More often than not, what you're changing instead is you've got a woman who you thought was going to be WWC and it turns out she's Medicaid. Does that make sense? Mm-hmm. And I would just say with those clients to be cognizant of whether or not in that period between her filling out the paperwork and getting enrolled, what date ended up being her effective date for Medicaid, and is Medicaid paying for the procedures in the meantime? Because if your system is set up where automatically that payment is retroactive, and I know some people's systems are like that, then that does mean that you need to go back in here and change it from Medicaid to WWC, or the reverse, rather.
Right, and I think agencies are already dealing with that.
Yep.
CCGP agencies.
But now you have a new path for her to go through.
New things to deal with, so yeah.
You have a path for her to help her.
Yeah, absolutely.
And call Kristen or Nick, like, as those come up, because I think it's, here's the idea that they can help you walk through what to do and what needs.
Yep, and we can identify also, we identified, I think, within the first month of the pilot project that there was this issue of women needing to move from WWC to the care coordination pilot project. And so we built in the capacity to move fairly easily between the two. There's no easy way in ECAS to get both of them, so that's not an option right now, unfortunately, but you can bounce back and forth between the two, so don't feel like if you listed service delivery, you can't change her. You can totally change her from care to care coordination if it turns out she gets enrolled into Medicaid for some of her services. Okay. Just let us know when those weird things come up, and we'll hopefully help you do the data entry and then maybe log it so we know if we need to discuss it further and make other changes to the system.
So *6 for questions. Do you want to go back and just see if there's any chat things? No? Okay. Hopefully, our goal was to make the data entry not be a whole bunch of new different things that you weren't used to doing.
Exactly.
I think, you just have to get used to some new caution flags, but it's really as simple as what is her insurance and what is, and consistently putting the funding source. Otherwise, no new data entry.
Before you move on, though, actually, I have a couple questions. Are agencies who are individuals who already have ECAS access able to start doing CCGP data entry now?
Are you asking me that?
I'm asking you that. Not them.
You. So you're asking for their capacity?
No, I'm not asking for their capacity. I'm asking for, is ECAS ready for them?
Absolutely.
Okay.
Yes, as we just demonstrated, it was ready.
Well, that's tough.
But that was training.
Okay.
Yes.
Okay.
Yes, it is ready. You can do. You could have done data entry last week, so you could do data entry today, and we'll, theoretically, we'll attempt to create a grant activity statement next Tuesday, the 17th, for you for your care coordination.
Oh, really?
Yep.
Get coordinating.
Oh, baby. That's crazy. That's good.
That would be exciting. We don't expect it, but that would be exciting.
Okay.
We shall see. But yeah, absolutely. If you want to, enter a couple of cases this afternoon just to see how it works, go for it.
What day is the date that it's effective?
February 1st.
February 1st.
Don't enter any care coordination cases before that. Otherwise, ECAS knows the start of your contract, and it'll help you. It'll tell you that you entered that a little too soon. And you could just let me know or let Nick know, and we'll delete it out so you don't have random caution flags bumping up your to-do list at ECAS.
Well, and I think this is, I feel like we addressed it now. I'm not sure the answer is, if they already did say they did the PAP or the mammogram in January, but now their contract started and they're navigating the biopsy, because they had an
It's based on the last procedure date, so I think that would be fine.
So they
technically,
couldn't.
You don't know, will ECAS allow any pay for if there's a procedure before February 1st?
I can check, but do you want it to be okay with that?
Well, what I
think
would
it
want
would
is
be
if they had done any case management
In February.
last week or this week for a biopsy that they.
That's why so ECAS mostly behaves on the last procedure date. So if the last procedure date of the screening was after the start of the contract period, I'm pretty sure ECAS would be fine with that, and it sounds like you would be as well.
I think so.
If the colpo happened February 10th, then case management obviously occurred somewhere between February 1st and February 10th.
Mm-hmm.
Are you?
Yeah.
Otherwise, I can add an extra rule that says the first, but I don't think it. So that is our official guidance. So long as the last procedure happened within the contract period, you're fine. If for whatever reason that guidance doesn't turn out to be how ECAS is behaving, let me know and I will make sure that works. But our official suggestion is you can include any case so long as the last procedure falls after February 1st. Okay, so agency reimbursement, again, very, very similar to regular service delivery. It's generated through ECAS after all errors identified through ECAS have been resolved and data entry on those clinical services have been completed. You're reimbursed based on our bundle payment system, which we just went through the level 7s and the level 8s. Level 7s are patient navigation. Level 7s are patient navigation and level 8s are for case management. These are cumulative, meaning that the $105 for a level 8 includes the $45 from the level 7. I'm going to pop back really quickly to make sure I'm covering everything. As I mentioned earlier, you need to really choose a path between WWC's service delivery and WWC's care coordination program. You can't have both. You are free to switch back and forth between the two as you need, but in the end of the day, every client can only be assigned to one or the other contract. We reimburse for each cancer screening based on its individual clinical outcomes. And you as an agency for WWC agreed to accept these fees as payment in full.
So one thing is each client, but each cycle. So if she was clinical services and then she finished her cycle and then she got Medicaid, the next cycle could be care coordination.
Could be.
And also we try to mimic this program as closely as possible after the service delivery program, except that we're not reimbursing for the clinical services. So along those lines, our rule changes that occurred in December, where we will now reimburse for multiple screenings in a fiscal year, apply to the care coordination grant program. So if a client, for whatever reason, let's say she has breast cancer screening services paid through Medicaid, we reimburse for the care coordination, and then 6 months short-term follow-up. If she needed a mammogram or an ultrasound, it would not be true if she just needed a CVE. But we would reimburse for that second screening in the same fiscal year because that rule change applied across the board for WWC. So I'd already kind of jumped ahead to this, but these are the two levels for the breast screenings. The level 7 patient navigation, we reimburse $45 for it. Your BPS charts and the toolkit go into very specific things that are included in that level 7, very specific types of navigation activities that we want to make sure occur.
I think Angie talked about those.
Yes. Yeah. Good. So that's what's included in the level 7. A level 8 is once you have an abnormal and you need some diagnostic services. I think the only thing that's a little weird about this for care coordination is, again, it's structured based on WWC, so it's all based on what procedures occur, even though we're not paying you for the procedures. So you can only achieve that level 8, the care coordination case management reimbursement, after diagnostic follow-up has occurred. Very same thing is true for the level 7 and level 8 for cervical services. the only difference between a level 7 for cervical and breast, breast level 7, you have to have a mammogram. Cervical level 7, you can just do the education and get reimbursed for it.
And let me just say, because I think that maybe we're not talking about, the reason that is because it's based on the clinical services. When do you get paid for patient navigation in the WWC clinical services payment system? So for cervical, you get paid at the level 1 when the PAP gets complete.
Before, when the office visit gets complete.
But I'm saying that PAP or office visit at the level 1, and for breast it's level 2. So we're tying it to the same things that are tied to when you get paid for patient navigation for the clinical services as well. Which is, it feels a little weird when you pull it out separately. But
so what does the reimbursement cover? It covers enrolling the client. It covers the patient navigation and case management services for breast and cervical cancer screening, and then data entry into ECAST. Adjustments. So adjustments to reimbursements occur the same for the care coordination grant program as they do for the service delivery. Were an adjustment or a change you would just see on your next grant activity statement.
So if you move her from WWC or to WWC, you might see a negative. That would be the only thing.
And this is a little bit later in the presentation, but your grant activity statements are totally separate. It's a separate contract that you have, obviously, separate grant activity statements. So when we talked about switching from service delivery to care coordination earlier, you're going to see that in two places. You're going to see it be fully taken back from service delivery and fully given to you in care coordination, or the reverse. So that might look a little weird at first if you're only looking at one grant activity statement or the other, but reimbursements where you go from a level 7 to an 8 work just as they do with regular direct care service. You just see that adjustment in your next grant activity statement.
Right.
When do we reimburse? We will generate this grant activity statement at the exact same time as we generate your regular service delivery grant activity statement. It will be a separate statement that is created, so you'll have to run basically your grant activity statement report twice in ECAST instead of once. You'll see under contract type, and I have a screenshot for you on the screen. You just select a different contract type. You select CCGP. This is one place where maybe we were a little I don't know, it's a little weird because you select WWC for service delivery, and here you select CCGP. So we might have to think through that one a little bit. But yeah, so to see your grant activity statement for the care coordination project, you would just select this slightly different contract type. Same is true for the budget tracking report. It does work for care coordination. You'll note that because we started our contract so late in the fiscal year, the fiscal year percent will be off for the remainder of this year. Don't worry about that a whole lot. It'll look more normal next fiscal year. Technically, we just started really late in the fiscal year, so we're not trying to dock you for that. But you'll have these, once you have these slides, you'll have kind of a quick reference for how to find your grant activity statement. Just remember, you're going to have to run it twice, print it twice, and if you're not seeing a client when you're doing reconciliation, ask yourself, do I have both grant activity statements? Is she in one and not the other? And then also, if you see somebody go from a level B4 to a B8, well, that means you're going to see minus, $1,500 on your WWC service delivery statement, and then you're going to see the 105 on care coordination. So it might feel a little weird. It'll look a little weird. Additional reimbursement. What is this? Oh.
Sorry.
What is this?
Oh. Those of you know. So WWC is offering each of you agencies, a separate reimbursement. So this is separate from ECAST, and this total amount didn't show up on your contract, and so when you got a contract with a certain amount, this was not included. So after you actually generate a grant activity statement, so either your February bill run or March or April, whatever, whenever's your first paid activities, you can send WWC an invoice for the cost, and I did send each agency the amount we will offer you for this, basically costs associated with establishing these processes and procedures. Some agencies it's going to take a lot more work. Some of you may have new forms, new people touching the paperwork, just all kinds of different things. So we wanted to assist you in getting started, and we want you to be successful in implementing care coordination grant programs. So, and you can check in with us on what that amount should be. We'll be contacting you because we'll see when your first bill is generated, so we'll know that too. So I wanted to be sure to mention that.
It's basically startup costs.
Startup costs.
You're not, once you get, it's not really included in the cost, the patient navigation and case management. That extra stuff it's taken you to do to get
and
this in place.
We couldn't figure out another way to include that, or we can't include that in ECAS. It just doesn't work with how we pay. It doesn't work with bundle payment systems, so we wanted to offer this separately.
And did you say that you already sent that number out to agencies?
I did in December. I sent that number out, so I can send that out again.
Could you? Because I believe Christy received that, and she no longer works here, so I'm not sure.
That would be a problem, wouldn't it? Yeah, I will send those out again.
Okay, thank you.
Okay, awesome. I will. That's very, very doable. So we have a couple more sections that I wanted to cover. Some of this stuff is really, we already talked about. Angie mentioned that agencies cannot subcontract for patient navigation or case management services. But you really, and you're not required to have subcontracts for this grant program, but you are required to be able to refer clients for those same services, those mammograms, ultrasounds, breast biopsies, colpos, whatever, MRI, whatever you need to do if they're not being directly provided by your agency.
This was us learning, we were like, it's subcontract. I'm like, but we're not with insurance. They're not subcontracting for it. The insurance pays the other provider. So it's, I think, becoming familiar, as you guys already probably are, of like,
more than we do.
Who takes Medicaid for X and who takes Blue Cross Blue Shield for Y, and that's making sure you refer to the right places.
Right. So that's all. CWC does plan to offer technical assistance for this project, for this program. So number one, we've provided this training today. We will provide additional training. We will have other meetings if you want. We will do whatever you need us to do. So keep in mind, we're going to use the weekly newsletter, WWC Update, to communicate with you about this program. We have a section of the toolkit. We will have forms on our website. Until we do have those, we will be sending those to you via email, attaching them to email. What I wanted to do is ask this group if you would be interested in a regular meeting to talk about this program, maybe for technical assistance, a connection. What I was thinking originally is, how the clinical services program has regular the HIC call monthly, most months. That's a way to connect and answer questions and talk about
hot topics,
areas of interest and of importance to that program. And they're very much, you guys are them, so that's where it gets a little confusing. But I would like to offer a time where we could possibly offer more assistance, answer questions, talk about what successes and challenges for the Care Coordination Grant Program. So just right now, does anyone have any thoughts on that? I'm thinking of a quarterly meeting.
Can I try unmuting everybody?
I could. I'm a little afraid of that, but just wanted to see what your thoughts were on what we could do. And I'm going to mute you, but if I have to mute you again, *6. So.
All guests have been unmuted.
Okay. Hi. So you're all unmuted. Does anyone have any thoughts on maybe a quarterly get-together for this particular grant program, or monthly after the HIT calls? I don't know. We hate to add too many meetings, but I would like at least a couple times to get together and talk about what you're learning about how to implement this program. Or I could just survey everyone.
Well, an agency, if you're assigned to Chris, normally for your program coordination, you can give her a call anytime. If you're Mrs. Ivy, if you're assigned to me, you can call me at any time outside of these meetings as well, I believe.
Absolutely.
Right?
Oh, yeah. So your program coordinator has not changed. Your nurse consultant hasn't changed. Emily's still Emily.
Yeah, things I wondered for a call, just even as we were talking, it's like, Medicaid has their transportation benefits, and I know I've talked to at least one of you about some of the trickiness with that. It seems like it might be a good forum to be able to share kind of what you've learned, if there are specific, private insurance that are harder to navigate than others, or some of those barrier reduction things that are, because it's a little bit different when they are insured versus uninsured, and that's really where this program came from. Is actually we were hearing from a lot of you that actually when they have Medicaid, it's sometimes harder because for clinical services, we have a subcontract with provider X. That means they'll just take my client when I call them. But if I call them and tell them I have a Medicaid client, well, then they don't. They have a quota or whatever. And so I'm just wondering if I'm kind of echoing Chris, do we need some sort of forum to share experiences, questions, that kind of thing?
I think quarterly meetings would be nice, at least.
Quarterly. Okay. And I also want to throw out there. Not every month. I'm voting for that too.
Every other month, I say.
Oh, every other month. Okay. Or every other. Yeah. We might start that up front. We might do that. So what is this? February 11th. So we might meet in mid-April just to check in on everyone, make sure you're doing okay.
More frequent in the beginning.
And then go from there. That might be a way to go. I'm also going to encourage you to go ahead and on the even months, there's an ECAS technical assistance call. Go ahead and ask care coordination questions of that as well. So don't feel like everything has to be separate, because really it doesn't have to be separate.
Yeah, that one is the one with Nick on Wednesday morning.
Oh, no.
Different than the users group.
That's different than the users group, yeah. So there are opportunities to learn a lot. So are there any questions or suggestions or thoughts? I think we are winding down. We are. I'm showing my last slide. Is there anything that we didn't talk about that you have questions about?
I just want, this is Emily, and I just want to say, we are so excited about this and really do see this as being one of the future directions of WWC. I think clinical services there'll always be a need, but as we've seen, it's been shrinking, and it may continue to shrink. And that this is really an area where I feel like you all and WWC can really make a difference in helping these women who, by definition are low income, probably unused to being insured, most of them, and really helping them navigate that system to make sure they get
screenings and diagnostics that they need, that really is going to contribute to our overall goal in the state of reducing breast and cervical cancer morbidity and mortality. Look at me connecting to the logic model. And so I'm really excited. The pilot project is really exciting, and I'm really excited to have 14 agencies on board, and really, because I'm just like I hope you do have stuff in the bill run. I'm like just like antsy debating, like yay, what's going on, what's happening? So. You know, we're glad to partner with you on this. Thank you for being part of it.
Thank you. Well, if there are no more questions, I think we will end the meeting and stay tuned. One of the first things I will do is send out the presentation and send out
that
something else.
Stuff, as much as we can find out about.
Oh, I was also going to send out your numbers for your additional reimbursement amount. We will be sending you things. So, thank you. Goodbye.
Anytime. Bye, guys.